Hello everybody, welcome to the live stream. Again, 2 o'clock on a Friday afternoon. I hope you can hear me okay. Let me know in the chat if you can't. I promise I'll keep an eye on the chat this week because there was a couple of questions came in last week and I didn't see them, so I do apologise. And that's actually one of the reasons why we're talking about what we're talking about today, because Janet asked me in the chat what happens if your patient's ventilated and their SATs start to drop. What do you do then? So that's the conversation we're going to have today. Before we start, though, I just want to point you to my other resources. So you can follow me on Twitter at @CCPractitioner. I'm still quite active on there. If you send me a message, I generally will pick it up pretty quickly, and I always try and respond to any messages that anyone sends me on there. Or you can go to my website, which is the www.criticalcarepractitioner.co.uk, as you can see there. I've got blogs on there, I've got YouTube videos on there, and I've got my podcast on there. So my podcast is up to episode 160 something now. I've actually stopped counting. I was having episode numbers before each episode, but I've dropped them now because I want people to see what the episode is about rather than what episode number I'm actually on, because that's not important to you. You just want to know what I'm going to talk about. So I've dropped that now. This episode here that we're recording live will also be as a podcast episode. So if you want to listen to it again, by all means do download it as a podcast. And then finally, there is my teaching page. This is where I sell some of my courses. I've got one called Mechanical Ventilation or Mastering Mechanical Ventilation, which is actually on offer at the moment. It's normally £57. It's over 3 hours of videos. There's a podcast episode in there as well, which you get to keep. Normally £57. For the last week, it's been £27, and that finishes today. So if you want that, go and get it. And it comes with a guarantee. If it's not for you and you ask for your money back within 14 days of purchase, I will give it you back, no questions asked, without hesitation. You don't need to give me a reason. Just tell me you want your money back. That's fine. No offence caused. You'll get your money back. Anyway, the other thing I wanted to tell you about was, because eventually these are going to be moving over to the Facebook group Critical Care Skills with the Critical Care Practitioner. I do need to think about that title because I'm aware it's very long. But that's where eventually these live teaching sessions will go to. And once I've built up a big enough audience there, probably exclusively over there, just so that I can get people in chatting to each other as well. It's not just me that wants to talk to other practitioners and other nurses within critical care. It's each other. So I'm trying to create a bit of a family atmosphere over there so you can chat to each other as well as me. So go and visit there as well. But without further ado, let's get going. So, like I say, last week I was asked what would happen if your patient desaturated. They've been ventilated. They may have been ventilated for a little while. They may have just been ventilated. And the saturations start to drop. So really, the first thing to cover here is let's differentiate between whether this is an emergency situation or whether it's just a steady drop in the patient's saturations, which you don't quite understand why. So I'm going to cover both, really. And I think I'll start with the emergency situation. And this is the process that will go through my head. And I have plagiarised the notes a little bit here from Life in the Fast Lane as well. It's a wonderful site. If you, all things critical care, go to Life in the Fast Lane. So I've used their notes a little bit here, but these are things that I was already aware of. So immediately, if there is a dramatic drop in the patient's saturations, then what goes through my head is the mnemonic DOPES. So DOPES. We need an S on this slide, don't we? But it's DOPES. So what does that stand for? Well, D is about displacement of the endotracheal tube. So are you sure that that tube is still in the right place? It's very easy for it to happen sometimes, isn't it? That the patient's rolled or turned or coughs dramatically and the tube gets displaced as a consequence. Sometimes that tube can be sitting just below the vocal cords. The patient only has to give a bit of a cough, or when they're rolled, they give it a bit of a cough and a splutter, and that tube can then move above the vocal cords, and suddenly you've lost your cuff seal, and all that air is no longer going into the patient's lungs, it's just leaking around them. So we need to think about displacement of the endotracheal tube. And as well as coming up and out, it can also go down. And if it goes down, what can happen is it can go down into the right main bronchus. Anatomically, the tube, if it's going to go down and go down anywhere, it would generally go down the right side because of the angle in that tube, in the trachea. So it could have just gone down the right side. So now we're just ventilating one lung rather than both lungs. So it's important that we understand that that can happen as well, because that can cause a marked drop in the patient's saturations. O in dopes is for obstruction of the ET tube. So is there an obstruction in there? Now, for the ventilated patient, the two most common obstructions are secretions. That's the most common one, probably. So there's a big plug of mucus in there that's got stuck in the tube, and suddenly the air can't get in. And as a consequence, what you're going to need to do is suction that patient. It could also be that the patient is a little bit light and they're biting down on the tube. Sometimes, if you want the patient to remain light, you might need to put something like a bite block in there to stop them biting down on the tube. So that could be the obstruction as well. Your airway pressures will probably go up as a consequence as well, because if the patient's biting on the tube, then the pressure in that tube is going to be consequently much higher. Is there a problem with the patient? And I'm going to go on to talk about this in a moment, but talking about some of the problems with the patient that might be causing an issue with those saturations just suddenly dropping. Is there a problem with the equipment? So does your ventilator seem to be working properly? And one of the things that you should always do with a ventilator that you think is not working properly is work from one end to the other in a logical and structured way. Now, what I mean by this, what I would do is start from the Schrader valve, so where it's plugged into the wall, and this is the way I was taught to check an anaesthetic machine when I did anaesthesia. Check the Schrader valve, work your way from there all the way back into the ventilator. Check your ventilator settings, then get the tubing from the ventilator to the patient and check all the way along there in case the ventilator tubing itself has become kinked, or it's suddenly got a hole in it for some reason, or it's become disconnected. You can normally tell it's disconnected because it just doesn't sound right, but it could be that it's disconnected and under the pillow, for example, or under the patient's arm. So just check logically and in a structured way from one end to the other, and then hopefully you won't miss anything. And then the S in dopes is for stacked breaths. So what's a stacked breath? Well, if a patient starts to become bronchospastic, what happens is that the air that they breathe in then finds it difficult to come out because of that spasm in the bronchioles and the bronchi. It's harder for the air to get out because those airways become narrowed. So what can happen is that the ventilator, not being aware of this being a problem, will then just give them another breath before the patient has had a chance to breathe out the whole of the last breath. So their volumes will start to rise, and you'll be able to see on the volume curve and on the flow curve as well that the patient isn't having adequate time to actually breathe out. The volume curve won't return to baseline. It will start to creep its way up from the baseline each time it tries to breathe out again. So that's the stacked breaths. So that's the kind of things immediately. So what would you do under those circumstances? Well, what I would do, if the patient suddenly desaturates, and if you've worked in IT, you've probably seen others doing this. If they suddenly desaturate quite markedly, what you're going to do is disconnect them from the ventilator and put them on the water circuit. The water circuit is the green bag that inflates with oxygen, and then you can gauge, especially when you have some experience, you can gauge how hard it is to actually bag the patient for yourself. Now, if it's very hard to bag the patient, then either there's an obstruction in the ET tube, there's an obstruction in the patient's airway, or possibly they've collapsed a lung and suddenly you're only ventilating one lung rather than two, and that would increase the pressures as well. If it's very easy to bag the patient, but the saturations are still down in their boots, then it could be that they have a problem with something like a pulmonary embolism suddenly. And if you've listened to any of my lectures before, a pulmonary embolism, basically, it doesn't matter how much oxygen you give the patient. If there is no blood going past those alveoli, then there is going to be no transfer of oxygen between the alveoli and the blood, because there is no blood going past. So that's something else to bear in mind as well. Assessing the patient's obviously really important. So we've said that they've desaturated, and this is perhaps something that we can do in a little bit more of a calmer time. So let's say the patient has suddenly started to gradually lose their saturations. Then this is where I would use something called the MASH approach. So the MASH approach stands for movement of the chest, arterial saturation, skin color of the patient, and hemodynamic stability. So look at the patient's chest. Does the patient's chest seem to be rising equally, or is there movement only on one side? Does the patient's chest suddenly look hyperexpanded? If it's only moving on one side, then that could be for two reasons. It could be that the endotracheal tube has slipped down to the right main bronchus, so you're only ventilating one side, or it could be that the patient's had a pneumothorax in one lung, so again, effectively, you're only ventilating one side. It could also be that the patient has got a huge collapse of one side. So they've got atelectasis. This is where the alveoli collapse when there's a big plug on one side. So it could be that actually there's a big plug in there. There's been a collapse of a lobe or a segment, and that might make the chest movement look a bit strange as well. So you're going to be looking for that. You're obviously going to be taking an ABG. ABG is going to be useful. Sometimes the saturations and the ABG don't necessarily reflect each other. So you're going to do an ABG and just check that, my patient SATs are 75%. Is that actually reflected in their blood gas? Because sometimes saturations can be unreliable as well. It could be the patient's cold. It could be the patient shivering. It could be the patient's black. We know from the recent COVID experience that saturation probes don't measure saturations in those those in the black and ethnic minorities. It doesn't measure so well. So we know that's an issue. It could be that they've got false nails on. Hopefully you've already noticed this. But for lots of reasons, the SATs may not marry up with the arterial blood gases. So you're going to need to check your gas as well. Check the skin color of the patient. That's the S in MASH. So does the patient look like they've become hypoxic? Are they going a bit blue around the gills? If they are, then obviously there is a problem. And just remember that the saturations do lag a little bit behind the true oxygen saturations of the patient. So the patient could be a lot more hypoxic than perhaps 80% because it takes a little while for them to catch up. So you do need to be aware of that as well. And have they suddenly become hemodynamically unstable? Has their blood pressure suddenly dropped very dramatically? Has their heart rate just suddenly increased very dramatically? All of these things could affect your oxygen saturations and make you think that the patient is becoming unwell. It may be that if the patient is difficult to actually ventilate, if the problem does lie with that ET tube, and there is little chest movement and it's hard to bag them, the other thing that you need to look at is your end-tidal CO2. So if you've suddenly lost your end-tidal CO2 and the patient still has an output, so they haven't gone into cardiac arrest, and they've lost their end-tidal CO2, that means that we're not getting carbon dioxide back up the lung for the end-tidal CO2 monitor to monitor. So it could be then that the tube has slipped and perhaps gone down the esophagus, or is not actually patent at all, in which case we try and pass a suction catheter. If we can't pass it, or a bougie, to check that it's not obstructed. If it is, then that ET tube is going to have to be changed. So I said when we talked about the calm and the dope, that we would, with the dope as well, we would talk about some problems with the patient. So what are the common reasons for a patient's saturations to drop in a calmer situation? Some of the things that you might want to look out for, some of the things that could have happened. Well, more dramatically, they could have had a pneumothorax. That tends to occur quite quickly. They could have had the atelectasis. Again, that can happen quite slowly though, so those lobes can collapse down over a period of time rather than suddenly. It could be due to pulmonary edema. So maybe the patient has become very positive over the last few days. Perhaps they suffer with a bit of heart failure anyway. And it could be now that their lungs are starting to fill up with a bit of fluid, and therefore the gas exchange becomes worse. And this might be where you see this gradual decline in oxygen saturations, and you're going to have to compensate initially by giving them more oxygen, perhaps giving them more PEEP, because remember, your FiO2 and your PEEP are going to be the two things that are going to change the patient's oxygen levels. The tidal volume and the ventilation rate are going to be the two things that will affect their CO2 levels. So it could be that once you've done that, it may then be one of the medics who needs to review the patient and perhaps think, do we need to give this patient some diuretics, or do we need to filter them? Perhaps they came off the filter a couple of days before and their kidneys aren't quite ready and we may need to refilter them. Bronchospasm is a possibility as well. Bronchospasm does tend to happen quite quickly. The patient will have quite a wheeze, the airway pressures will go up, and that's maybe when we need to start giving them nebulizers, some steroids. We perhaps need to take the ventilator off so that we can get some of that air out of the patient's lungs. Sometimes you'll see doctors disconnect the patient from the ventilator and literally press on the chest wall to try and get some of that gas out of the patient's lungs. Or it could be, as I said, a pulmonary embolus. So again, this could be either dramatic or, it won't take very long for a pulmonary embolus to show itself if it's big enough in a patient. Most patients who are ventilated these days are going to be on things like enoxaparin to stop their blood from clotting so much. And as a consequence, a pulmonary embolus is probably unlikely, but it should never be discounted. And then finally, the last thing that could be causing a problem, so if it's less acute, let's say your patient's saturations have been dropping and dropping and dropping, you're going up and up and up on the oxygen. Probably the most common thing you need to think about is the fact that the patient has developed another infection. If they've had one before, this could be an infection on top of an infection, and it could be that the patient's temperature's gone up, their heart rate's gone up, their noradrenaline requirements start to get a little bit higher. So all of that will tell you that potentially this could be a hospital or a ventilator acquired pneumonia, in which case if the temperature's high enough, you're going to be taking cultures, you're going to be doing a blood gas, and it could be that we might need to give them fluids, for example, or increase the noradrenaline, get a chest x-ray, and then we'd speak to the infectious diseases department and just ask them what they would do as far as antibiotic cover is concerned. So they're the things to think about in the acute situation. So just remember DOPE and MASH. Think about doing a structured from the Schrader valve all the way to the patient, or vice versa, whichever you think is the most likely. If you think the problem is more likely at the patient end, start at that end. But work your way along the whole system, and then hopefully you should be able to diagnose the problem, and hopefully somebody should be able to help you. I hope that's been useful. Next week, I'm not sure what I'm doing next week. If anybody wants to suggest a topic, then that would be fabulous as well. If not, I'm sure it's going to be something possibly ventilation-wise again. If not, I'll surprise you next week with something. Think about joining me in this side, the Critical Care Skills with the Critical Care Practitioner Facebook group. Like I say, eventually these lessons are going to be going over there. Yeah, that's all I've got to say. So thank you for joining me.